אחר הצהריים נעים לכל מי שאיתנו. אנחנו נעבור מהר מאוד להדגמות שמצפות לנו על ידי פרופסור אלן פרוזטי, שיציג את ההדגמה, ופרופסור פרנק יאומנס. I'm just saying in Hebrew what is expecting us this afternoon. And now I'm going to talk a little bit. We are going to talk just very shortly about the wide circle project that you have in your papers over there. And I'm going to say it in Hebrew to our friends here, our colleagues. על הבמה, ידידי אילן ועמיתי האהובה עמיתתי, זה נשמע כמו במיתתי, לא אחזור על זה, אבל, אוקיי. יפעת כהן, ממייסדות מכון אופק ל-DBT. אותי אתם כבר מכירים שאני שותף לאילן, למכון שהוא פרי החלום של אילן, לא המכון, סליחה, המרכז הישראלי למנטליזציה. ואני אגיד ממש בקצרה, המרכז הישראלי למנטליזציה הוא מרכז שנוסד לפני 10 שנים, הפעילות שלו רק הולכת וגדלה, והמטרה הבסיסית שלו היא להגביר את הפצת הידע, גם הידע התיאורטי וגם הידע הפרקטי ב-MBT, בטיפול מבוסס מנטליזציה. במהלך 10 שנים הללו, למותר לציין, אולי קצת התחלתם להבין את זה בתוך השיחה שהייתה פה היום, העולם ה-MBT גדל, משתנה, מתפתח בצורה דרמטית, במידה רבה בהשפעת לא רק המוחות הרבים שעוסקים בו והפרסומים שמתרבים, אלא גם כן המחקר הרב מהתחומים השונים. ובמרכז שלנו אנחנו משתדלים להגיע לכמה שיותר קהלים, גם בשירות הציבורי וגם במסגרות פרטיות. במשך 10 שנים הללו, העשור האחרון, אנחנו לא רק הרצינו, לימדנו כנסים, אלא ממש הדרכנו מהדרכה בסיסית ועד הדרכה מתקדמת יותר, כ1,000 איש. אז אנחנו רואים בזה הישג, אבל עדיין התחלת הדרך. אנחנו מחפשים להביא לכמה שיותר אסימילציה של הידע הזה, לא כדי להביא לאיזושהי תחרות עם הזהות המקצועית של כל אדם שבא מהמודל שהוא בא, או מהקונביקשן המקצועי שלו, אלא כדי להרחיב את האופקים, או אם אתם רוצים את ארגז הכלים, ולאפשר לאדם לחשוב באופן משוכלל יותר על הטיפול שהוא יכול להציע אל מול המטופל המסוים שהוא עובד איתו, כי כפי שאנחנו רואים, ובכנס הזה אנחנו מתמקדים בטיפול באנשים שסובלים מהפרעת אישיות גבולית, צריך לחשוב באופן שהוא לעתים יוצא מהקופסה שהיינו בה עד עכשיו. אז אנחנו מחפשים את שיתופי הפעולה, אנחנו מחפשים את המקומות שבהם יש עניין להכיר או לקבל הדרכה, ויש לכם בדפים גם את אופני ההתקשרות איתנו שתדעו את זה. תודה.
שמחתי כשאילן ויואב הציעו לי שהאנשים במכון אופק יצטרפו לפרויקט המאוד חשוב הזה, שאילן תכף יציג אותו, ובכמה מילים אני רוצה לספר לכם על מכון אופק. מכון אופק הוא מכון שהתחיל בערך להתקיים, בנינו אותו לפני כ7 שנים, העמיתה שלי דוקטור נחמה פרסלר ואני. הוא התחיל, עוד לא יעזנו לקרוא לו מרכז DBT, הוא התחיל כמרכז פסיכולוגי פסיכיאטרי, אבל היה לנו ברור שאנחנו רוצים לעשות DBT כטיפול אינטגרטיבי ויעיל. אלה הדברים שעניינו אותנו אחרי הרבה שנים בשירות הציבורי. במהלך השנים האלה נאספו איתנו כ30 אנשי מקצוע נפלאים ומוכשרים ומסורים שמוכנים לעבוד עם פסיכופתולוגיה קשה ולא כל כך אלגנטית, ובמהלך השנים האלה המקום באמת התפתח מאוד, גם במובן הטיפולי, יש היום כ-12 קבוצות במכון, גם של הורים, גם של מטופלים, עם טווח הגילים התרחב, גם מספר המטפלים ומספר קבוצות ההדרכה. המכון נמצא באבן יהודה, אבל הקליניקות נמצאות לטיפול אינדיבידואלי, נמצאות ברחבי הארץ, בעיקר באזור המרכז, וכל הקבוצות וקבוצות העמיתים וההדרכות הם במכון. במהלך השנים גם הפצת הבשורה הולכת ומתרחבת. אנחנו בעצם מדריכים ומלמדים ונותנים תוכניות הכשרה רבות מאוד, גם באופן קבוע במרכז הישראלי ל-CBT וגם בהרבה מאוד מרפאות ציבוריות, מרכזי יום. עכשיו יש לנו פרויקט גדול עם משרד הבריאות, שנתנו ימי הכשרה מרוכזים, ואנחנו ממשיכים הדרכה במספר מקומות בארץ לאנשי בריאות הנפש הציבורי, ואנחנו באמת מאמינים שחשוב להפיץ טיפול שהוא כה יעיל, גם לאנשים שידם אינה משגת. אנחנו עושים את זה דרך הפצת התורה במקומות הציבוריים, ועכשיו אנחנו רוצים לאפשר גם טיפול פרטי, בעלות נמוכה יותר, ולכן שמחנו מאוד להצטרף לאילן ויואב, ואני מזמינה את אילן להציג את הפרויקט.
תודה יואב, תודה יפעת. בקצרה, יפעת גנבה כבר את ההצגה, זו המטרה של הדקות הבאות, זה להרים פרויקט שתמורת עלות נמוכה, מטופלים שלא יכולים בעצם לממן עלות טיפול, יוכלו לקבל טיפולים שהם טיפולים מבוססי ראיות ושיוכיחו את היעילות שלהם. אנחנו מדברים על טיפולים בעיקר בהפרעות ויסות. הרקע לזה הוא רקע של ההתנסות שלנו בשטח. לגבי אנשים שסובלים מבעיות בוויסות רגשי, שאינם מקבלים טיפול בגישות יעילות ומבוססות מחקר בגלל הקושי למימון טיפול, ובצד זה הניסיון שלנו לקיומן של גישות שהן יעילות בטיפול. אנחנו הצגנו פה 3 גישות, ישנה עוד גישה אחת שבכנס הזה לא הספקנו, שזה הגישה של טיפול ממוקד סכמה, אבל בסך הכל אנחנו מדברים על 4 גישות שהן יעילות בטיפול, והשאלה אם ניתן לתת מענה לאנשים האלה שמשוועים לטיפול ממוקד ויעיל. אנחנו מדברים על טיפול ממוקד ויעיל, על טיפול של 2, והמענה שחשבנו עליו הוא המענה של פרויקט המעגל הרחב, תכף נבין למה המעגל הרחב, והחזון הוא שאנשי טיפול המעוניינים ללמוד גישות חדשות ויעילות מוזמנים להצטרף מבין הנמצאים פה, והמטרה היא בעצם להרחיב בהדרגה ובמהלך השנים את המעגל הזה של המטפלים והמטופלים בגישות יעילות ומבוססות מחקר, והמענה שאנחנו מצאנו לנכון לבנות אותו הוא מטפלים שמעוניינים בהכשרה יוכלו לפתח מיומנות בגישות האלה, והם יעברו הכשרה תוך כדי מתן טיפול בעלות נמוכה למטופלים שאינם יכולים לממן טיפול פרטי, ומתוך המטפלים האלה שיסיימו את ההכשרה ואת ההדרכה, יהיו כאלה שיעבירו את ההכשרה לבאים אחריהם, כך שהמעגל של המטפלים עם המיומנויות בגישות היעילות יתרחב ויגדל, וכמובן שבמקביל יתרחב ויגדל גם מעגל המטופלים, שמקבל את הטיפול באחת הגישות הללו. אנחנו מדברים על הכשרה והדרכה בטיפולים אישיים, קבוצתיים, זוגיים או משפחתיים, כרגע בגישות MBT או DBT, יכול להיות שבעתיד אנחנו נרחיב את הגישות. המעניין הוא כך שהנרשמים לפרויקט יקבלו הכשרה תיאורטית במספר ימים מרוכזים, ההכשרה תינתן ללא תשלום בקבוצות, ואחרי ההכשרה הזו המשתתפים יקבלו הדרכה קבוצתית שבועית, אחת לשבוע באחת הגישות, תמורת תשלום, לא גבוה גם כן, ובתמורה הם התחייבו לקבל לפחות, אבל המינימום 2 מטופלים בעלות נמוכה, או פרו בונו, אנחנו נראה לפי מצב המטופלים, והמטופלים האלה במסגרת הקליניקה הפרטית שלהם, והמטופלים יופנו ממסגרות בריאות הנפש הציבוריות שקיימות, אחרי במקומות שהם לא יכולים לתת מענה למטופלים האלה. בגלל תורים ארוכים וכהנה וכהנה. מי שרוצה להירשם, אז שולחן הקבלה כבר לא קיים, השקף לא עדכני, הוא נסע לירושלים, שולחן הקבלה, יש לו הופעות בירושלים, אבל שמנו דפים, ממש ביציאה ממול יש שולחן, שמנו דפי הרשמה, מי שרוצה להירשם, מוזמן להירשם, או ליצור קשר, אנחנו נשאיר כמה דקות את השקף עם הפרטים גם שלנו וגם של מכון אופק, ואנחנו נשמח שאנשים יצטרפו ויתנו יד לאיזשהו תהליך שאנחנו מנסים לבנות אותו עכשיו, ואולי עינת גם תדבר על כך בהמשך, לבנות את הקבוצה של האנשים שעובדים בארץ עם הפרעות אישיות גבוליות, ומוכנים גם לתרום מהידע והניסיון שלהם לאנשים שלא מקבלים את הטיפול המתאים. אנחנו מזמינים עכשיו לדמונסטרציות, נכון? סליחה, אוקיי.
מזמינים את עינת.
כן, עינת. דוקטור עינת אספלר.
תודה. I will excuse, I will say one more sentence in Hebrew, as it's, I think, concern only the Israelis in the excuse that I will say also a few sentences in Hebrew. It concerns only the Israelis in the audience. רציתי להוסיף גם שבמסגרת תפיסה, ככה שמעתי היום בבוקר את פיטר אומר שאם אנטוני היה יודע שאומר עליו שהוא סוציאליסט, אז הוא היה כועס עליו, ואני לא מתביישת להגיד שאני סוציאליסטית, ובמסגרת התפיסה הזו אנחנו מנסים לקדם בבית הספר במכון מגיד מלגות הצטיינות למועמדים מצטיינים מבריאות הנפש. אנחנו כבר שנתיים נותנים מלגות, 10% מהתלמידים שלנו לומדים ללא שכר, והם צריכים להיות מהשירות הציבורי, מתוך תפיסה שמי שנשאר בשירות הציבורי והמוכנות לעבוד בשירות הציבורי, כדי שאנחנו נתרום את חלקנו להכשרה ולעידוד של תפיסות גם דינמיות, גם מוכחות מחקר וגם דיאלוג בין גישות. אז בתוכנית התלת שנתית עם גישה דינמית אנחנו נותנים מלגות, ואני רוצה עוד 2 דקות לפני הדמונסטרציות, אנחנו 700 איש, אתם מרגישים את זה בטח בכניסות וביציאות ובדוחק. ההפקה הייתה מורכבת מאוד, והיא לא הייתה מתאפשרת בלי 2 נשים שאנחנו רוצים לתת להן כאן כבוד. אז מאיה אורון, בבקשה, שהייתה על הפקת הכנס באופן מלא ב3 חודשים האחרונים, ועשתה הכל. ועוד מאיה צולר. And now we switch back to English, and I'm proud to invite Professor Ellen Provozeti to demonstrate treatment with Ruth that will arrive. It's the same story as in the morning, and we'll see what happens in DBT.
Hello, I just wanted to orient everyone a little bit to the structure of DBT that I mentioned on Friday. So if we're 4 months into treatment, which I think is the scenario, Ruth would have been completing what we call a diary card or a monitoring log about various things like self-harm and her mood and other things on a piece of paper daily. She'd be doing that. And so I assume she'll be bringing that with her. We'll see. And also, if she had a crisis this week, which apparently she's had, she would have called me or one of my colleagues for some skills coaching, because she's been in treatment for some months. She's been learning some different skills to handle her emotion. So she would have called, and I would have had a conversation with her, possibly one of my colleagues, but I would have been available to have a conversation with her. Now, she might have hung up, it might not have gone well, or it might have gone very well, who knows, but I would have been available to her by telephone. Probably not by texting, by the way, but probably by telephone. She would have, for example, my office phone number she would have my home telephone number. And we probably would have had a conversation, or at least attempted to have a conversation. So that's just the background. So I'm going to be sitting, I suppose, and waiting for her, and we'll see if she shows up. I'm so glad you're here. I was just about ready to give up on you. I think you need a microphone.
Yeah.
Yeah. Hi. Hi. How are you doing? You look like you feel terrible.
Thank you.
You're welcome.
Well, you're just suggesting that I look terrible.
I said you look like you feel terrible.
Well, I do.
Okay. So you got your diary card. That's great. Here, let's go over it together, okay? Let's have a look. Let's set our agenda. Okay, so let's see. So help me. Come. Okay, so do we want to start on the agenda with how you're feeling right now? Would that be helpful? Is your mind here or someplace else? Okay, so we'll put that on the agenda first. So tell me what we see here. Self-harm.
Yeah. 6, yeah.
Yeah, which day?
2 days ago.
Yeah, you cut yourself?
Yeah.
Okay. Did you need medical attention?
No, not really.
No. Okay. And right now, do you have any urges to harm yourself or kill yourself?
No, I feel like I want to die.
You feel like you want to die, but no real urges to kill yourself. You're not going to run out of the session and go jump out the window or something.
Don't know.
Don't know. Okay. So that's got to feel pretty awful and scary. Okay. Well, maybe we start with that, and then we'll come back and talk about what happened on Friday, unless they're connected in some way. Okay. What else do you want to put on our agenda? We only have half an hour, of course, because you're a bit late. But if we have time, what else do you want to put on our agenda?
That I feel really sad.
Sad? Okay. What happened?
I don't know what to do because I don't know how to live without Yossi.
Okay, so this has to do with what we talked about on the phone on Friday? Okay, so, and Friday was your self-harm, and that's part of what you're upset about right now. Okay, so they're connected, right? Okay.
I think so.
All right. So let's just start with, Ruth, could you look at me? So I can't quite tell right now whether you're only feeling really sad, but able to focus and do some work together, or if you're so overwhelmed with your sadness that you can't focus. And I think you're answering my question now.
I don't know. I don't know. I can't really understand you. You're pushing it.
Yeah. Okay. So that's answering my question. Thanks. All right. So how about we do a little of look up at me? Okay. Let's try a little something to try to help bring your emotion down a little bit. Okay. Now, do you remember what's worked? What's worked the last couple of times? It seemed to me that you just really bringing your attention into like what we're doing and getting your attention out of what's going on in your head a little bit, that sometimes that's very helpful. You want to try that for just a minute? And try just describing what you notice around the room. Around the room, me. Describing your emotion, but not so much the racing things inside. What do you notice?
Don't know, the glasses.
Okay,
the
good.
Glasses.
Would you like a glass? Me too. Would you like a glass of water? Yeah. Okay, why don't you take a sip? Take a deep breath. Take a sip. Hold the water in your mouth. Swish it around. Notice how it's cool. Okay?
Yeah.
Deep breath. Okay. Good. Okay, very good. Okay. So, this has been a really hard couple of days, huh? Okay. So, now tell me, can you tell me, I don't know if you want to use a number or a word or something, like from 0, if 100 is just so, like your emotions are just on fire, okay? That's 100. You're just out of control and don't know what's going to happen next. And 0 is not upset at all. Where are you now?
7, I think.
7 out of 10?
I think so.
And when you walked in the door?
I don't know. I didn't want to come here. I didn't want to come here.
Okay, so it was hard to come here, but you got here. That's really good. Sounds like your wise mind, maybe, right? You came anyway, even though part of you didn't want to, right? Part of you must have wanted to because you're here, right?
Why are you smiling? Why are you smiling?
I'm happy to see you. Yeah.
Are you?
I am. And I'm glad you came.
You're not judging me.
What do you think? Seriously, this is a great place to start. What do you think? When you look at me and you remember the times we've been together before, what do you think the chances are that I'm judging you? Even when
I don't know.
smiling.
You said I look terrible.
You want to try that one more time?
What?
Is that what I said? I said you look like you feel...
Are you mocking me?
You feel terrible. Okay. So now, come on, into the room. Now notice what... Try not to be in your head about it. Try to come into the room with me. What do you notice? Am I mocking you? Really? What do you know?
I don't know.
Well, I think you know. Right?
Well, I'm here. No?
You are here, right? And am I glad to see you?
I don't know. You smile.
What do you think?
You smile.
Okay. What do you think that means? Come on. We've known each other for a few months. We've been together quite a few times. What do you know? Not what is in your head, but what do you really know? Right. Exactly. Okay, good. That's really good. That's hard. Does that feel better when you notice that? Yeah, of course. Good for you. Okay, so now shall we... Now, can we work on this when you're at 7? Or do we need to help you bring your emotion down a little bit more? Because I want to talk about what happened on Friday, but I want us to be able to do it in a way that's very helpful and not going to just trigger you and make you feel worse. Okay?
Yeah.
Is 7 okay for that, or should we... Okay. So what your job is as we talk about this, you got to keep bringing your attention back to the fact that we're having this conversation, okay, and that we'll figure this out. We will figure this out, okay? And it's just you and me to figure this out. All right. So on Friday, when you phoned me, we left it at that point that you were going to try some skills, okay? And on your diary card, it says you did self-harm. So at some point after that, you self-harmed anyway. So we got off the phone, I don't know, what time was it? It was late in the afternoon? Yeah? And what time did you harm yourself?
It was just around 10, I think.
Okay,
11.
so some hours later. Okay. Did something happen in between our phone call and that? Or was it you still reacting to the earlier things with your mother-in-law?
I just felt so lonely.
Okay. Were you alone at that time?
Yeah, because everybody was at my mother-in-law's.
Right. You had gone home, right? Okay. Did you use the skills we talked about? Did you try to soothe yourself?
I tried, but I couldn't. I just couldn't help it because I felt so lonely. It felt so empty. Yeah. Okay.
All right. So are you feeling that way right now?
What?
Are you feeling that way right now as well?
I can sense that you're trying to get to me, but I just...
Yeah.
I don't know if I can trust you.
Well, trust is kind of a big word. If you ask, what do you think I'd say if you asked me what time it is? What do you think I'd say?
What?
Do you think you can trust me to give you an accurate time? If you said, gee, what time is it? Do you think I'd tell you the truth?
Yeah.
Okay, so you can trust me for that. Okay. If you asked me if I could pick up 200 kilos, could I do that?
Oh, I'm so tired.
I know, but I couldn't do that, right? Good. Tired is good. Look up at me. So I don't want you to get into your head about this trust thing, because you can trust me about some things and not trust me about others, of course, right? What is it you're worried about trusting me with?
If I'll trust you, and then you'll just be like everyone else, and you just throw me.
Just throw you, like
fire me.
Fire you. Okay. Did I fire you last time? Think about it. Remember. Okay. See, here's the thing. Ruth?
Yeah.
Okay. So on the one hand, right, you've got some emotion. You've got fear. That makes sense for certain reasons, right? Reasons like you've had some terribly painful things go on this week, and you've had some abandonments in your life that were very, very painful. On the other hand, what? What's on the other hand? What's the other part of reality right now?
That I'm here.
You're here, and I'm here. And I'm happy to see you, right? Even when it's a terrible day for you, I'm still happy to see you. I'm very sad that it's so hard. Okay? So when you have worries that I'm going to throw you, bring yourself back to your actual experience and what you know in our relationship, okay? And it's okay to check that out with me if you want to. But I actually think if you listen to your wise mind, we practice this all the time, right? If you listen to your wise mind, I think you'll know. Okay? What is your wise mind telling you right now?
I'll try.
Okay, great. All right. So where do you want to focus on? It sounds like you cut yourself late in the evening. So there's a long chain that started at your mother-in-law's house, right? You told me about on the phone.
Yeah.
And then through our phone call, and maybe you tried some skills after our phone call, but maybe they didn't work so well, or maybe they worked for a while, but then something else happened, and you ended up cutting yourself. So it's hours and hours of things. What do you think would be the most useful piece of that to focus on? Any ideas? It seemed to me that on the phone, the part that was overwhelming you was the same that you're saying right now, is that you're really afraid of being alone.
I was alone.
Right.
I was alone, and nobody was there for me.
Right. Right, and that felt very painful, and you said empty, right? So maybe we could talk about how you might have handled that situation then. Maybe we could practice it now.
How?
Okay. Well, let's think about what skills. First of all, are you feeling empty right now?
I don't know what I feel like my heart beats, and I feel like I have a headache.
Panicking. You feel more like you're panicking? Okay. Mm-hmm. Panic? And what are you thinking about when you notice the panic? Because 5 minutes ago, you weren't so much panic. And where was your attention then?
I'm too frightened. I'm too frightened to...
Yeah. Okay, so tell me what...
I'm too frightened to talk about it, because I just feel that when I'll tell you what I did, you just hate me. And
Oh, okay. So there's something else there on the chain. So something on the chain that even talking about it... All right, well, so obviously, words are not that dangerous, okay? So you got to tell me what happened and get over that, and then we can actually do something about it, okay? So what happened? Now take a deep breath and keep looking at me, okay? The shame comes up. You just talk to me and notice my reaction, not your fears of my reaction, okay? Go ahead. What happened? What'd you do that you're so afraid of telling me? Right. Yep. Take the hand down.
I just
Nose up, chin up. There you go. That's right. Breathe with me. One more. Okay. Well, what'd you do?
Hand down. Well, I called Yossi's mom, and I said that I'm sorry that I was like that, and that I shouted, but I apologized, and the bitch was just like...
Okay, so now try that again without the judgment. Okay? One more time without the judgment. Be descriptive.
Because I called and I said...
no, okay.
I said I was sorry.
Okay.
And it was just silence there. She didn't...
Okay.
She didn't say okay, and she didn't...
Okay.
She didn't... And she used to love me. She said she loves me. She said, you know, and I took care of her when she was in hospital, not her son who was working all the time.
Hang on, just on Friday night now. So you phoned her, and she was silent. You apologized, which I suppose was hard to do? You feeling embarrassed?
Terrible. It was terrible. I had to drink almost a whole bottle of wine for that.
Okay, so that wasn't really you calling.
What?
That was you on drugs calling. That's different, right? It's a good target, but it's hard to be effective when you drank a whole bottle of wine, right?
I couldn't do it either.
Well, I couldn't drive a car if I drank a whole bottle of wine either.
I can't drive a car.
Well,
I can do anything with a bottle of wine. It's not that much.
Bullshit. Okay.
I told you hate me.
Yeah, right. All right, so, but she's silent, and what emotion did that pull up in you?
Rage.
Okay, so you felt a lot of rage. Now, what were you thinking in your head? Because you just told me what you were thinking in your head, right? You used the B word, right? And so that's part of the rage, right? But what if she's not a bitch? What if she's...
She is. She is.
Ruth, stick with me here. Let's let the judgments go. Because what happens in your brain every time you do that? Does that help your emotion go down, or does it make it go up? Right. So let's try to be descriptive. So she was silent, and that was very provoking. And you didn't know what that meant.
Very painful.
Very painful, yeah. And honestly, that would be painful for me too. I think that would be painful for a lot of people when you're trying to apologize and it's not clear if someone's receiving it. Maybe she's judging you. Maybe she doesn't know what to say. I don't know. We're not inside her head, right?
I know. I noticed the look she had.
Well, she was on the phone.
And Yossi said that she was afraid of me. She was afraid of me. Why? She was afraid of me. I didn't do anything. I just injured myself. I'm not injuring her.
Hang on. Let's just do one thing at a time, okay? Slow down. We'll go there too. But on the phone, okay, so you're judgmental, and she's quiet, and then you get rage. Do you see, you might have missed a little piece of emotion here, or maybe a couple. Do you see some other emotion there, maybe, that's relevant?
I don't know.
Okay, let's try it. Can we try it?
Yeah.
Let's imagine, I know this is a little bit trivial, okay, but we'll try it anyway, okay? So let's imagine that I borrow a book from you, okay? And I lost the book, okay? I'm going to apologize, and I want you to be quiet, okay? Don't say anything, all right? It's like, oh, Ruth, I've got to tell you, you know, that copy of your favorite book, I left it in a coffee shop. I feel so terrible. I'm so sorry. Of course, I'll buy you a new copy. Okay, how do I feel? You're not saying anything. Okay, we'll stop the role play. How am I feeling?
I don't know what you feel. How can I know what you feel? I'm not in your head.
Well, I'm not being judgmental of you, right? So without the judgment, what am I feeling? What am I wanting from you?
You want me to say, sure, yeah?
I want to repair our relationship, right? And you're not, at least not at the moment, indicating you're willing to do that. So that's got to be very, very sad. I got to be extremely sad and disappointed about that, right? And also maybe a little embarrassed. I lost your book. Maybe that's a bigger deal to you than I realized. Maybe it's the same for you on the phone with your mother-in-law. She's silent, and maybe you're feeling really sad. You know, you said later you felt very lonely. Sadness and loneliness go together. Does it sound right as we say it? Does it sound like maybe that was a very sad moment too? Yeah, it does. Okay, right. Okay. So take a breath. That's good. Put your hand down, because your hand down, because you don't need to be embarrassed about feeling sad. Keep looking, because you need to know you've done nothing I'm judging. Okay. Breathe and feel sad. That's really good. Let yourself feel a breath of sadness. It makes sense. Makes sense. Okay. All right. Now, one difference is that I'm making it very clear to you that I'm not judging you, right? And still you have some shame coming up, right? And she was saying nothing. That's That's provocative. That's hard, right? Okay, so would it be fair to say that when you got off the phone then, you've got a lot of different emotions? You've got sadness and fear, like what's going to happen, and shame, and maybe also this, this anger that comes out of being so judgmental. Okay, so that sounds like being overwhelmed to me. Yeah.
I couldn't tell, I couldn't...
Yeah, you were overwhelmed. Yeah, right. Okay, so we have to have, it's very clear, we have to have a better plan for when you get overwhelmed. We've got to be able to sort this out more carefully and really give you some very specific things you can do in that situation to manage the overwhelm, okay? Because then each one of those emotions has some things that are worth us working on, okay? But we have to be able to work on them in a way that doesn't overwhelm you, okay? Make sense? All right.
So.
Which one? So we've got 4 different emotions to work on, and we have just a few minutes. Which one do you want to start with?
I don't know. I just feel so empty. I don't know if it's the rage. Rage feels me. When I feel rage,
yeah.
I feel.
At least you feel.
At least I feel.
Okay. I want you to notice though that a moment ago when you were feeling sad, you definitely felt something there too. Right? But there's something about sadness that's in some ways harder to feel. In some ways.
Yeah.
Yeah. What makes it harder?
Because it feels so empty. It feels like a desert. It feels so empty.
Okay.
It feels like I have
so
to,
let's
to feel it. I can't feel anything, so I just have to cut myself. You know. Sometimes just to because I suffer.
Great. So let's start with the sadness and let's help you feel alive and feel yourself, so you're not feeling so empty with sadness. Because sadness. Honestly, the sadness makes a lot of sense, doesn't it? I mean, there's nothing crazy about that. Right?
I don't know. When I feel sad, I feel like I can't control it.
Find the sadness now, and let's stay with it for, let's see, 2 minutes? 2 minutes? Okay. That's a lot. 30 seconds?
Yeah.
Okay, 30 seconds, okay? And I'm going to try to coach you, okay? But we're going to take not that much sadness, but this much sadness, okay? All right, so I'm going to remind you of a little piece of this, and then what I want you to do is just follow, I'm just going to coach you through it, okay? So I want you to remember this moment on the phone, and you're apologizing, and she's silent, and you're really worried that you've done some damage, and you're feeling lonely, okay? Now, you feeling a little lonely right now? Okay, now where do you feel it? Can you feel it in your throat?
I feel it here.
Okay, stand up with me. Stand up. Okay, now, I want you to feel it in your chest. What does that feel like? Tell me, describe it for me.
It feels like cold.
Cold. Cold? Tight, loose? Pressure? Pressure. Cold pressure. Hard to breathe. Okay, so if you have cold pressure making it hard to breathe, let's try the opposite, okay? Let's put your arms up in the air, okay? Seriously? Take a deep breath. Easier to breathe? Seriously. We got to work on the smoking too. Okay? I have no idea if that's true. Okay? Easier to breathe? Okay, now I want you to bring your attention. I know it's just a little piece of it, but notice the breathing part is easier. You just managed a little tiny piece of the sadness. Okay, no. Arms back up. Okay. Okay. Now, take your hand, put it on your chest. Does it feel a little warmer? A little less pressure? Can you lean a little bit? Can you stretch a little bit? Just lean a little bit to the side. Okay, roll your head around, stretch your neck out a little bit. Okay. Now, who's doing this right now? Can you feel that Ruth is standing here breathing, managing your sadness, your breathing. You're letting some of the pressure go. Keep your attention just on this little piece, okay? Can you notice that you're doing it? Who's doing it?
I think I'm doing it.
You're definitely doing it. That is you. You are here, okay? Now, does that feel a little tiny bit less empty right now? I know it's not all better, but just a little tiny piece.
I feel you.
I'm here too. That's good. That's very good. Then you're definitely in your wise mind because I'm also here, okay? Okay, you with me? This is good. Does this feel better?
In a way.
Okay, so this is a little bit like the first time, if you're like you're afraid of the water, right? And you go into the water the first time, even if it's only 1 meter deep, it's scary, but you find that you're floating, but you're still scared. Okay, but I want you to notice you're also floating. And yes, there's a little danger, right? Because there's still water, but you're also learning to float. You see that?
I feel like I want to hold on to you.
Okay, go ahead. Okay. That's good. That's okay. Now that triggers some more sadness, right? Okay, so do the same thing. Notice it in your body. Don't be thinking about it. Keep the focus on your body. Deep breath. Okay? Okay, good. Now you notice that you're here. It's not just me. You're here too. Okay? All right, now try it again. You're here. You're a whole person, right? I want to feel yourself here. You're the one noticing it. You're the one doing it. Okay? You feel better, right? It's because you're being really skillful. Okay, so it's like you went from being afraid of the water to floating, and now you paddle a little bit. Okay? You're not in the Olympics yet. Okay? Don't need to be. You just have to not drown, right? Okay? So this might be all we're going to do for today because we only have 3 minutes left according to our clock, our live clock. So this might be enough for today, is to practice this, okay? Now, the question is this something now, you've done it with me, okay? Now let's sit down again. So what I want you to do is I want you to close your eyes and do the same thing. I want you to notice. I'm going to be quiet, but I'm not going to leave, okay? I promise. I'm going to be right here. Yep. Yeah, and you can check it out. You can open to check if you really want to. But I want you to try it yourself. I'm going to be quiet for 30 seconds. I want you to take 3 deep breaths of sadness. And when you're done, I want you to, boom, open your eyes and come back to all your attention back to me. Okay? Ready? Go ahead and begin. Great. Great. Okay. You did it. And you did it without me. Okay? This is terrific. All right. So what I want to do is I want to do this one more time. Okay?
How am I going to do it, you know, just when I'm there?
Well,
when I'm without you.
You're going to pull out your iPhone and we're going to record it together. Okay? And when you're home, you're going to listen, you turn it on, and you're going to practice with the recording. Okay?
Okay.
You willing to do that? You just did it without me, but this way you can take a little bit of our practice together with you. Okay? You willing to try that? And I know this is a really, really hard week right now. Okay? So what I want to do is have you practice that today, and then I want to maybe set up a time to talk tomorrow to see how the practice is going, because we might want to add something to the practice to make it more effective depending on how it goes. Okay? Willing to try?
Yeah.
Okay. Now, let me pause. I know we're out of time, so let me just wrap up. I don't really know if you have an iPhone with you, but that's really what I would do, is I would have her record what we're doing so that when she's dysregulated in the moment, she actually has that to play to pull her back.
So I put my alarm, like it's like an alarm.
Exactly. Okay. And I know we're out of time, so I'll stop here. Thank you. Thank you, Ruth.
I'm delighted to call in Professor Yaaomens. Frank, are you here with us? Sure, of course. We shall discuss what we are witnessing now with Professor Provsty and Professor Yaaomens shortly. At the discussion later. Professor Yaaomens, are you with us? Please come in.
Where should we start? Oh, Where would you like to start?
Start with the fact that I tried to see you and you couldn't find the time for me.
When you called 2 days ago?
Yeah.
Yeah. I was sorry about that, but...
You're sorry about that?
It sounds like you're not sure about my being sorry about that.
I don't think you're sorry about that. I don't think you care.
You think, pardon me?
I don't think you care.
Well, that's a pretty major concern. So when you called and I explained I didn't have time, that was in support of your thinking I don't care. Yeah. Must have been a little hard to come today then.
I didn't want to come at all. I'm really, really, really upset with it because you didn't find the time for me, and I think you should because you know I needed you. And you're just acting like everybody else. I can't trust you.
Yeah. Well, I remember when I did return your call, I suggested some contact on the phone. Do you remember that?
Yeah.
Yeah. But at that time, it didn't seem to appeal to you.
I couldn't take the phone. I needed to see you. I needed to be with you.
Well, you know, when we set up the treatment, I remember we discussed this possibility. And I remember I explained that it would not be realistic. I simply couldn't possibly be available 24 hours a day. And I remember we discussed that at the time. Do you remember that discussion?
But I needed you. I needed you 2 days ago. It doesn't matter. You know, when everything is okay. But when it's not, I need you to be there for me. You know, the fact that you have so many patients and you have your career and you have everything, it's just not enough. It's just not enough for me.
Well, it sounds not only like I wasn't there 2 days ago, but it seems like you don't imagine you're on my mind at all.
I don't think you think about me. Do you ever think about me?
Well, I'd like to look at the different possibilities. I could certainly say to you, I do think about you, but I'm not sure how much difference that would make about what's going on in you. Do you think that would convince you?
No.
Okay, then we agree on that. No. So I think it would be better to look at the doubt rather than to try to give you a reassurance. But there's one part of this picture that I'm a little concerned about. I've been waiting for about 30 minutes and wondering where you were.
So you could call me? Tough. You were concerned. I don't think you were concerned about me being late.
Yeah.
I couldn't come. That's the time I can come.
Oh, just parenthetically, if a patient doesn't come, I always call after 15 minutes go by. But, so, I would have called that in this scenario. Well, the reason I brought up your being late was I was kind of concerned whether you had decided not to continue with our work together. Because it was...
I don't really understand why I did, you know, appear.
Why you came at all.
Yeah.
Yeah, well, that may be an important thing to look into. But I wonder if you had any thoughts about what it was like to be sitting here while you were not yet here.
No.
No. Yeah, so in your mind, you couldn't imagine that I would be thinking of you then?
No.
No, okay. I notice you seem rather nervous right now. Do you notice the leg shaking?
It's the way I am.
Mm-hmm. But it might help to put some of that into words. So...
it's just I'm so angry, you know?
Well, I didn't know. So could you tell me more about that?
I feel that when I called you, you were the only one that I could think of that can help me. But you too. You just like everybody else. You just don't give a shit about me. So I'm angry. I'm angry at you as well. think...
You know, it seems like you're very and increasingly sure I'm not here for you. Is that the way it feels? I didn't answer when you called. Let's put it this way, I didn't pick up the phone when you called. When I called back, I didn't have the time to see you that day or the next day. So from your point of view, I'm just not here for you. Is that how it feels?
Yeah, it feels so... I suffer. It feels so sad.
So sad, okay. And what are you sad about right now?
I feel that nothing is going to get better. Never going to get better.
Yeah, but you seem actually more sad than when you came in. Would you agree? It seems like as we've been talking, you've got more sad. Yeah, I'm kind of curious about that.
It's just... It's like... I thought I'll be better, but I'm not.
Yeah, no, I understand, and I think we discussed it's probably going to take a while, but I am interested in how you've gotten more sad over the past 5 or 10 minutes, and you seem to have noticed that too when we stop to think about it.
I almost want to believe you.
Well, I think that might be what's making you sad, because when you came in, you were kind of, we have an expression, loaded for bear. I'm not sure that translates very well, but it seems like you came in with a pretty angry attitude about my not having been able to see you. As we've been sitting together, it seems to me that in spite of all your disappointment and all of your anger, there's something else going on right here, and I'm not sure if you would agree or disagree with that.
I don't know.
No, okay. But you do agree that you've gone from being more angry to a little more sad, would you say? I'm not sure how to understand that either, but I do have a hypothesis. Would you be interested in hearing it? Okay. Because when you came in 30 minutes late, and you were convinced that you may as well be late because therapy doesn't matter at all. Or at least I don't matter, or I don't care about you. I am not sure about this, but I wonder if, as we've been speaking, that conviction of yours has been questioned a little bit. Because at first you said, I don't think about you, I just think about my career. I just think about my other patients. That's very sad. I don't know what your experience is right now, though, as we're sitting together.
I feel you look at me. I can feel that you see me, but then I'm so frightened. I'm afraid of it as well.
Yeah. What's the fear exactly?
That you hurt me.
How would I hurt you?
Like you did.
Like not answering or not calling, not having. Yeah. So, if you begin to feel comfortable here, it actually kind of paradoxically would make you anxious, because then you're more vulnerable. You know. I think that's an important thing to look at, because if you're more comfortable being angry, that might make it a little hard to be close.
What?
Oh.
Sorry, I'm sorry. What?
No, perfectly all right. But it just seems as though if you settle into the view that I don't give a damn about you to begin with, then at least you know the way things are. Here you said...
I know it because I already experienced it, and I know it's because everybody that I met through my life is like that, so...
Everyone hurts you in the end. Yeah, I know when you told me initially about Yossi, your husband, you said he was perfect.
he was perfect, but then he started to grow cold, and he didn't want me to call him anymore. He didn't want me to he didn't want to have sex with me every day, and it's just he doesn't want. So I felt so lonely and so rejected that I started going out, you know, and I went back to drinking and going and having sex with strangers.
But what was it like when he was perfect? It would be interesting to hear more about that.
I felt so happy. I felt that he's like one, and he loves me, and he cuddles, and I felt that he loves me, that he accepted me, that I felt like he's really seeing me.
Is that kind of the way you felt when you were taking care of your mother-in-law?
When I was there and she said she loved me and nobody took care of her like I did, I felt...
Well, but I was thinking you were acting at that point like somebody taking care of her perfectly. You said you dropped everything, you were at her bedside.
Yeah.
Yeah. And so it would be understandable you might wish that I would provide that for you, the way you could provide that for her. So what I'm getting at is it does seem like in your mind there are times when you're very different from when you threw the knife, when you were a person who was totally full of love and concern for these people.
Yeah, but they don't appreciate it, and they're ungrateful, and then they don't see me, and I just, what do I have to do in order for them to see me and to be grateful, you know? And it was just,
yeah.
I'm trying to take care of everything, and I'm trying to get a grip on everything, and sort of lead my life, and be a good wife, and be a good mother, and be a good daughter-in-law, and it's too much.
And you said nobody sees you. Yeah. But I would get back to what began to change here. You said you felt I was seeing you, looking at you, and that you almost believed it. But could you say more what you almost believed?
It's like sometimes when I had with my uncle and with Yossi, that's like I could feel them. I could almost feel their love, looking in their eyes.
So there's a wish you could find that here. Or am I putting words into your mouth?
But then you throw me.
Then I would toss you away. Yeah. Well, what I'm concerned about, among other things, is that there could be a disruption of the work we're doing together, of our therapy, but I was concerned about that when I was waiting and wondering where you were, because I was thinking that you might have just stopped thinking about what we're doing here. That seems, well, can you say what you're thinking?
That's weird.
What's weird about it?
It's like if you care about me, you say it and you call and you have space for me. But if you're not there. I can't.
Well, what about, how does it feel right now in terms of being together?
With you.
With me, yeah.
It almost feels good.
Well, that's important to know, because there's something about a certain way you have that makes it hard just to be together. I mean, right now we have mutual eye contact. When you were shaking your leg more, I had a feeling you were more involved internally, and I was trying to see if we could kind of bridge that and begin to relate. And I think that's happening now. But I was curious also about how this corresponds to what you said is the most central problem you have, was the emptiness, the void, sense of nothingness. Are you feeling that right now?
I'm feeling, I'm just, I don't know what I feel. It's just like, you talk and talk and suddenly I feel like it's like all, I'm bewildered and I'm sort of, I feel like anxiety coming up.
Yeah.
You know, it's like feeling like...
But you're shutting your eyes again. We had eye contact for a while. What do you think is going on that you were shutting your eyes when you were talking about the bewilderment?
It's like I'm afraid of you getting inside me.
Oh, what is the risk? And actually, what do you mean about getting inside of you?
That then I'll be just so lonely again when you have enough.
That if we got close, then it would just end the minute the session was over. You know. And in your mind, I would be thinking about my other patients and my career, as you said.
Yeah.
That would be the case, yeah. But I keep getting back to not just today, but routinely, when we've had sessions, you've been generally quite late. Would you agree with that?
Late?
Yeah, late. Yeah.
Yeah.
Yeah. And when you talk about my not being there for you, almost every time we've got a scheduled session, I'm left wondering if you'll be there for me, if you see what I mean. You're not here, I am waiting. So it seems a little confusing to me which one is not there for the other some of the time. Oh,
no.
Oh, I don't know if that was clear because you're sort of chuckling.
It's fine. I never thought about it.
Oh, well, I have a hypothesis because sometimes it seems that you sort of are in a conflict about wanting to have me as your therapist and not wanting to have me as your therapist because you're sort of 1 foot in and 1 foot out. And there must be something difficult about being here fully, being here 100%.
Yeah, it's trying when I'm trying to be here, you know, totally with my heart. Yeah. I just feel so insecure. I feel like, you know, what am I doing? What am I crazy? Why am I being there? Because the moment I go out, you don't think about me, and I just keep on thinking about you and thinking about what I have to do in my life, and then I go back home and everything is so terrible, and I feel so sad and empty, and then I have rage, and then I just and I can control it, but you're not there, you know, and so it's just like I'm afraid of being there with you.
Because it just would lead to my tossing you, as you said. But I'm wondering how you get to the conclusion that when you leave the session, you leave my mind. I'm wondering, you know, where you get to that.
That's how it works, no?
For who?
You?
Well, that's what we're sort of wondering, because that's your assumption, but I'm not clear how you got to that assumption.
Because it just keeps on happening. It's just, hey, it happened with my other treatment, you know. It always happens.
What did happen with your other treatment? I don't recall.
That he didn't answer my phone calls, and he said that I'm too much for him, and that he can't deal with me. So
you seem to be getting anxious again with the leg and the arm. That had stopped for a while, so it'd be interesting to follow what that corresponds to, or maybe it's right in front of us. You just said your other therapist said you were too much, and that very thought. Maybe you're wondering if that's what's going to happen here next.
Yeah.
What about you would be too much?
Then you grow cold and you will want to see me again.
Yeah, but what about you would lead to that in your mind?
What?
What about you would lead to my saying you're too much and that I don't want to see you again?
I don't know, just be alone again.
Well, let's try to figure this out. You're being alone. How would that lead to my not wanting to continue our work?
Because if you'll get to know me and you see how terrible I am and that I don't worthy anything.
Well, that's why I'm concerned about your only being here about half the time. Because it is hard to get to know you. But I guess you're telling me what's behind that. You're convinced if I knew you, it would be over. And that's a pretty sad state of affairs. So my sense is you flipping back and forth between wanting to be here and wanting to avoid being here, because in some ironic way, your being here would lead to my rejecting you. But again, I think that's what we have to reflect on to figure out where that comes from. It seems to me that if one of us is not being very accepting of you right now, it's more you.
Because you don't know how terrible I am.
Well, I actually would be eager to know anything about you, as I said at the beginning of therapy, even though it sounds simple. The most important thing is for you to speak and communicate as openly as you can, and we're encountering what can happen. It seems like there are things that you're keeping to yourself and that are very much a part of how terrible you feel about yourself. I'm just curious, for instance, about the incident with the cookies. You remember the incident with the cookies?
I was really bad.
With what?
I was really bad.
Well, that's why I brought it up, because it's one of those things that you let me know about and then you shied away from. And that's an event that sort of popped up and then disappeared. And when those things happen, I assume there's something about that you feel terrible about. And if we leave those things unexplored here, you're never going to feel good about yourself. So why don't you tell me a little bit more about that right now?
It's just that I was sure that Yossi is having an affair in the office with some tart there, and he denied it. But I knew that he's lying. It's pathetic, you know. And I was like hanging out and watching him going out of work and wanting to see who he's going to smoke with and who he's going to having lunch with, and I knew that he's having an affair. So I was just. And I tried to confront him with this, but he said that I'm crazy and that's what I'm doing, and that he had enough of me, and he drew more distance from me. So I was really upset about it. So I cooked I baked cookies with laxatives and.
Well.
And I brought it to the office.
Yes. That was the story you told, but then it's like that story disappeared, as though we couldn't go back.
Because I felt, you know, he was having diarrhea and he really felt bad about it. But I was so happy that he was at home for a few days and I could take care of him. But I was so ashamed of what I did, you know?
Yeah. Well, since we're just about at the end of this session, I think there's a lot more to look at in terms of what you just described. You gave me a little bit more information about that incident. But I'm going back to, you're coming in here seeming mostly angry. We talk, we look at each other, you feel more sad, but then you feel nervous. And I want to link that up with what happened with Yossi, because, you know, you love him dearly. You think he's cheating on you. You do something to get back at him, and you see the consequences, and then you feel this terrible sadness for something you did that then you're not sure was the right thing to do. And I'm not here to tell you what's the right thing or
But you're not judging me?
Well, yeah, I was just going to say, I'm not here to tell you what's the right or wrong thing to do, but just to look at your motivations for doing it. Because I think if we understand your motivations more, you'll be able to make decisions more fully informed. But in a very minor way, I think when you came in here, first angry, then sad, the sadness might have had to do with some awareness that some of what you do takes away from our relationship. You assume there's nothing that I want to give you. You assume that I'll reject you. So you come late in an angry state. We connect for a few minutes, and then I think your sadness might be partly an awareness of what you can lose by backing away and entering into that anger that takes the place of a connection. What does this mean? I'm not sure what that gesture means.
Me either. I just feel like crying now.
Oh, well,
it's good.
I'm glad it's a good kind of a crying, but I do think if we continue our work, and I hope we'll have full time in our next session and the one after it, I think we could try to help understand why, as much as you love these people, certain things interfere with that, and it may not all be coming from the outside, if you see what I mean.
It's too much.
It's too much. Well, let me put it just more simply. I think, as has happened here with your denying us half of our time together, you may do things that interfere with how close you can get to the other people in your life too. Yeah. All right. I'll see you on Tuesday.
Thank you.
We're having a final panel and having a discussion, conversation of what we have been seeing in the last hour with the two presentations. So we would like to continue. אנחנו רוצים להמשיך. מי שצריך לצאת, אנא עשו זאת בזריזות כדי שנוכל להמשיך ולאבד את מה שראינו כאן. Sitting in a panel, Professor Yomans, close to me next, Professor Pruzetti, Dr. Ifat Cohen, Dr. Einat Aspler, ולבסוף, Dr. Perry Hoffman. Sherry, thank you for joining the panel. Please.
Okay. What we want to do at the end of the conference is to have some time to discuss the demonstration and to have a conversation. We'll have some time for questions from the audience at the last 10 minutes. Okay? So, do you hear? Okay. So first, yeah, we cannot see. First, I would like Alan and Frank just to say how it felt, because I think it wasn't that easy, and if it was similar to how it works in the clinic or a bit different, or
how did it feel? Similar? Well, it's, this is a contrived situation. So on the one hand, it's easier, right? Where'd she go? She's not going to go, you're not going to go kill yourself, right? So it's different, and there's not much context, in the real clinic situation. I of course have a 4-month history of treatment, and I've been able to know what's been helpful and not helpful in the past if she's had a crisis. She's in skill training. With the kind of relationships that she's got, she's almost certainly going to also have some kind of family intervention in our team. So there's a lot of other context that would provide more safety on the one hand, but also it would be real in the moment, so more provocative in a different way. So, but, you know, so I was lost, of course, at the beginning, just because I would be in real life with her, coming in and not knowing what was going on. And then it was a question of trying to figure it out within the model, you know, within thinking, always thinking, okay, she's dysregulated. What are both the proximal causes of that and the distal ones? And back and forth, if we can manage the proximal ones, we can deal with more distal ones. If the proximal ones are overwhelming, we have to manage those, or we can't do any work on anything else. So that's the very short version. Is that kind of what you're asking?
Yeah, to ask whether it refers to what you do in the clinic. If you feel it was a demonstration that refers to what you do in the clinic.
Sort of. Yeah. I mean, I mean, we don't really have the context, so it's hard to know. But I certainly have had many patients who come in with this kind of dysregulation, and I guess I'm also a little curious, you know, what it felt like for Ruth as the patient, for you as Ruth. Yes. We certainly could. Yeah. You want to come up and tell us? Yeah.
You're not in therapy now. Yeah?
No, you're not.
Well, I really enjoyed it. Enjoyed suffering. And I kind of felt the truth of the relationship, and of being guided by you and also because I'm very physical, so I could really take in the physical instructions, you know, the breathing, and I felt that it was working, which was really nice. It felt good. I actually felt that I can do it, and maybe, you know, going on with the diary and doing the changes slowly, step by step, day by day, and also feeling there was something about the phone calls and the fact that you mentioned the fact that you got a call tomorrow, and so it gave me this the character, it gave her strength, you know, to go out and knowing that you will call. You know, maybe I'm not sure, I'm going to test you, and, you know, we're going to have our relapses, but something about it felt right. That's it.
So, if it felt like a real session when I was doing the... Well,
not a real session, but does it refer to what you do in the clinic?
Yes. Well, it took a little time, because in order to do what I or any of my colleagues would do in the clinic, there has to be an affective link. You have to get a kind of a sense of what's going on emotionally between the two people. And it took a while to do that on stage. And as in a real session, one can never be sure if one is reading the affective climate accurately or not. But I did sense that underneath your anger, there was a longing that I was getting in touch with. So my job, as I saw it, was to try to look at what you were defending against with your anxieties about attachment. So my attempt was to try and point out shifts in what was going on between us as we sat together, number one. Number two, point out what I thought some of your acting out might represent, because I would see your coming late as an acting out of something you weren't really verbalizing. And then I did something which I would do in a session, but I might have done it a little more quickly here, was to bring in some information from prior sessions that provided a different side of the patient, because we always think we're seeing one part of a fragmented self at one moment in time. And I was seeing Ruth in her fear of abandonment. I wasn't seeing Ruth as the laxative baker. And yet I had that information. So my hypothesis that I was trying to get Ruth to consider was that if relationships do get damaged, there might be something in Ruth that she could consider that would contribute to that, because you, as I understood you, were feeling just the helpless victim of others' rejection that you assumed was inevitable, and I didn't think you were reflecting on the complexity of your reactions and interactions. So by the end, it seemed like a reasonably real session.
I felt a bit of a danger there, because like I felt like almost you know, uncovering the real me, which was so sometimes the balance between doing the character and impro in the character and what comes up, you know, the thoughts and the feelings, and it's sort of to realize how acting out this being passive aggressive about, you know, coming late, or even baking, you know, the cakes, the laxative cakes is something that is like it's cowardish in a way. You know, because it's like punishing him, and on the other hand, suddenly I realized that it's almost like in misery, you know, that she harms him in order to take care of him, and that was a new thought, and it gave Ruth a feeling of strength, which I could relate to and sort of think in a twisted way that he can help her get healthier. You know, and solving this feeling all the time, feeling the victim or victimizer. So it's maybe when, you know, as we go along, we can find this, that I can contain the good and the bad within, and it's not going to be just that or the other.
Something you said is very important in terms of our understanding of change, because if you recall the lecture from Friday, we do see this split internal world, and Esti was just describing trying to get in touch with both sides of it. But a corollary of our work is that if somebody's going to change, they're going to have to go through a phase of being more anxious before they can reorganize their internal system. As maladaptive as a split system is, it provides some stability. Ruth knew who the good guys were, which is Ruth, and who the bad guys were, which is her husband, her mother, me. And that was not a very happy life, but it provided you with some certainty. So there is inevitably some anxiety about how am I seeing things? Is it more complex than that? And I think you were describing that in your experience.
First of all, I would like to say that interestingly enough, even though the three therapists was from such a different way of treating, and you were so empathic, and the three of you, made real effort to ease the pain of the patient. It felt like you're working hard, and that felt good. I mean, I felt that you're really working. You're not just waiting for the patient to work, which gave me kind of a good feeling. I'm curious to know if, for both of you, if you found something like, Ellen, did you see anything effective, or would you comment if you saw something effective in Dr. Yaaomens' session, and if you would even think that something is missing after seeing that? Would you say that something is missing in your let's say, session, or we'll talk about the session, and vice versa. And also I would like in this regard to ask Dr. Yomens if you would think that working with the families, since Perry and Cheryl are here, I would like to, for you, if you can comment, if working with the families is something that you think can help in any way or be important in your work.
There were a couple of different questions in there. The first one that I got was, what could I relate to that Frank was doing that seemed like effective to me? Effective? Yeah. Well, no, from my perspective. I think Frank brought a very nice, non-judgmental style to a fair amount of difficult, both in-session behavior and reports of out-of-session behavior, like the laxative cookies. And that non-judgmentalism, I think, is extremely important. So, and of course, that's, I would imagine that's something that, well, not every therapy shares, but many share a perspective on that. And I don't know how you think about that, but I'm assuming you, I don't know, not that non-judgmental is the term that you would use, but yeah, maybe so. So it seems like that's something that I would say would be extremely important to get Ruth to then do anything in the therapy context. So where you go from there, of course, is going to depend on your model.
I think Alan's right. It's where you go from there. Because I was impressed with her response to some of the relaxation techniques. And I thought that was very nice. And as long as one can then go to what Ruth said was the part of herself she didn't want to get to, but I'm sure we both want to get there. Absolutely. Yeah. In terms of working with the family, I think that has an important role. Our model is mostly an individual therapy, and I certainly didn't have time to go into great detail about all the different elements, but with many patients, the majority, I would say, when we're in the setting up phase of the therapy, we have a family meeting. We think it's very important after our evaluation, when we have established a diagnosis, because like Ken said, you have to be clear on your diagnosis and share it with the patient and share it with the family. And we think that sharing of the diagnosis makes no sense without some psychoeducation. So we think it's very important to communicate understanding of, and I think as Ken said, or as I imagined you saying, because I've perhaps filled in with an example of mine, I have had so many patients come in convinced they have refractory depression. And it's such a relief that there's a different angle to look at, because some of these people have had courses of ECT and everything else that could possibly be given for a major depressive episode. So the psychoeducation is for the patient, for the family. Then the degree of family involvement depends on the specific case. With some young adults who are particularly conduct disorder, we might have monthly family sessions, but that's not the rule. The rule is we continue as an individual therapy, maybe periodic ad hoc family sessions if something comes up, or a different possible model is to have a concurrent family therapy with a colleague with whom we communicate so that things can be addressed in both therapeutic settings in a coordinated way.
Well, I wanted to address affect, and I'm wondering if you would be willing to come back and answer another question. You got away from me. So my thoughts are that we are talking about a phenomenon that involves extreme emotion dysregulation as a major component. And I noticed that in the role plays you presented with a lot of emotion, physical as well as body movement, etc. And I'm just wondering, and I also observed from both role plays this afternoon that both therapists were addressing your affect and your emotion in very different ways. And I'm wondering from the patient's perspective, from your role play perspective, if you could comment at all about what the different approaches, well, what they felt like as a patient. Thank you.
Sorry. It's like asking me which child I like more.
No. just maybe whether, well, just what the experience was like in the context of each approach.
I have to say something. Well, once, the first thing is that, you know, part of the way I was portraying this was because I did a research and I looked at people with this and now read in the net and blogs and stuff like that, so I could build this character that I could rely on and do it through improvisation, which is harder to portray. But so at the end of the day, I had to rely on myself, or, you know, on Asti and her feelings and what felt. And I think in each therapy it was another breaking point. You know, this sort of you have this moment that suddenly you feel, yeah, I can trust, and yes, I can go through this. And so I don't think that I can say this was more effective than the other, because it's like 3 different ways that all of them, and I could go on with each one of the therapies, and I think I could, I don't know if being healthy will be a purpose or a target, you know. Sometimes you can benefit from not being so healthy, but I do think that that there were 3 different moments, and even in the morning, I said that the moment that Peter Fonagy, when he said, I can understand that, and I can feel that, and I was like, can you really? And this feeling. But the moment he said, I can't even start to imagine the way you feel, that was it was like a moment that I could breathe again and start trusting him, because he wasn't snooty or you know, he wasn't trying to, he knows better than me, or being in this, he's got the box of magics and he can fix me. The moment I could see that there's a person there, and that was the most important moment for me, that he can empathize without being, you know, knowing the way I feel, because nobody can know the way I feel. So that was the moment, and I can say the moment with Frank, the moment I looked in his eyes and I felt like, you know, he's there for me, and I could see it in his eyes. It wasn't the manner of speaking so much as the way he attended me, and also, you know, when you insisted on me looking at you, you know, not shutting down and not. It's the moment, I think, that you find the person and you really connect, you know, in the eyes, in the soul, and you sort of start breathing, because you feel that you can maybe put your head just a little, just to trust a little bit, and then you go and you can start the tango of being a patient. Yeah.
Frank and Alan, I wonder if each of you could say, from observing the other, what did you see in the other's interview that was so not your orientation?
We tend not to do things that are directive. Only rarely, if, for example, Ruth had been dissociating in the sort of extreme way. By the way, we consider a fragmented, split psychological structure a form of dissociation, so we think all of our borderline patients have a dissociated structure. But if Ruth had been seeming not present, we do some basic grounding techniques, like please, put your feet on the floor, look at me. But beyond that, we wouldn't do anything like take a deep breath, stand up, raise your hands, because we're much more oriented to sort of meeting the patient where they are in their emotional experience rather than taking them out of it that way. If Peter were here, we could have an interesting debate, because he says sometimes we overactivate people and get too into their subjective experience. So we have to be cautious about that. But if there was one thing in particular we wouldn't do, it would be those directive interventions.
I think I think everything that we did is different, because the models are different. But I guess, the flip side of not being active in terms of a coaching her by the way, I want to be clear. There's a distinction, and I don't know if this was clear from the role play. We would make a distinction between her being dysregulated in the moment versus only upset in the moment. And I would completely want to not take her out of the upset. The upset is totally valid, it makes sense, and there's a lot of work to be done. And that's actually what I was trying to assess in the beginning. But once she was, in our definition, dysregulated, the idea is that cognitive processing goes away, no work can be done. And so we make a distinction between that. And I thought we went back and forth between you being only upset and being dysregulated. And that's something that I don't have much confidence about how I did it in this session because I don't know you. That's something I would take some time to trust my own discrimination ability there. So I wouldn't, if we did this all over again, I might do it a bit differently. I don't know, because I don't have a lot of confidence. But I did want to demonstrate both sides of that. But I wouldn't, in DBT, we wouldn't, just as you wouldn't do the directive, we wouldn't do the interpretive part. We wouldn't make any intrapsychic interpretations. Interpretation in DBT it doesn't mean even the same thing, so I wouldn't, we don't make those kinds of interpretations or do that kind of work. So that obviously is a big difference.
I would like to ask one last question before we open the discussion to the audience, and I would like to address it to you, Frank. I would like to refer to the point of disagreement in the earlier panel, and actually it's a world war outside, about the evidence-based. Because I know that usually the psychodynamic approaches find it hard to be evidence-based. I know when people ask me to give questionnaire to my patients, I resent it because I think it bothers the therapy. But I have this other side in me that says, but how do I know that it works? Mm-hmm. So when I looked at your session, I kept thinking, it's easier to measure skills. And I could not think of how you can take whatever was the complexity of what happened and to make measurements out of it. So maybe in general and maybe specific, if you can say, if you needed to make it an evidence-based, what worked, what were the variables that you would look in a session?
That's a wonderful question. It could be the topic for a seminar, by the way. But first of all, I think the psychoanalytic tradition shot itself in the foot when they would be so rejecting of research for so many years. And one of the things that I think has made Otto Kernberg, besides his theoretical contributions, a leader, is his openness to research when other analysts wouldn't do it. But having said that, the first challenge was to standardize an analytic approach more than had been done so far. And I think that's your question, is how did we do that? Because without going into a lecture on it, the psychoanalytic world offers people many very valuable concepts and many very valuable techniques, but doesn't usually provide a structured way of applying those concepts and techniques. The way I think of it, it's like you give the therapist or the analyst a not a grab bag, although that may be the word that fits, a tool bag, and just say, you know, use whatever tool whenever it seems like the right moment, and that's very hard to assess for adherence. So when we first set about writing our manual, which even though we call it a manual, doesn't look like a CBT or DBT manual because it's more open-ended, but it does divide the therapy into different phases. It does describe the tasks for the different phases, but most importantly, it describes the application of techniques given what's going on in the session. Otto Kernberg established a hierarchy of intervention, so depending on the particular problem, one has to address it. So I don't have time to show it you right now, but we have a whole adherence form so that if all of you were trained in that, you could now be rating my session with Ruth. And the adherence form covers things like, has the therapist attended to the frame? So in this case, for instance, I would have been non-adherent if she were half an hour late and I didn't bring that up. And Ruth didn't bring it up, and maybe I would have just listened to what she had to say, and I'd say, oh, by the way, is the frame in place? If not, is the therapist attending to it? Are there threats to the treatment? I thought I addressed threats to the treatment, but those are the easy ones. On the adherence form is also, is the therapist naming what seemed to be the active dyads in the moment? So I was trying to get at, Ruth seems to feel that I'm somebody abandoning her, but on the other hand, I feel she's doing some of the same by her lateness and so on and so forth. So we would rate if the therapist described a dyadic relationship. We would rate if the therapist pointed to any reversals in the relationship, which I felt I did here. You seem to think I'm abandoning you, but sometimes it seems like you might be abandoning me. Then we would address if the therapist seems to look at what is being defended against. And in this session, I felt that Ruth was defending against an attachment, a longing, what we would call a more libidinal desire that she was very afraid of because she's convinced it will only lead to hurt and abandonment. So we do have a way of rating our therapists if they adhere to this model. I've just given you a little nutshell. Does that answer your question, or would you like more details about that?
Yeah, it answers my question, but I'm not sure I completely agree that it captures the whole thing that happens in therapy. Not that I have an answer, or not that I think there is an answer, but I say that because I think measurement is indeed needed, but yeah. I think it's very complex to capture what happened, because when Asti or Ruth said what helped her is the feeling, or when she looked you in the eyes.
Yeah.
And I'm not sure what it was, because Alan asked her to look in his eyes as well. He did it differently. So in both cases, we can say, yes, looking in the eyes. But it was completely different.
Yeah. But what you're saying is one of the reasons I have an ambivalence about research in psychotherapy. I think most psychotherapy researchers are aware that you can study certain variables, but we're still learning what are the real variables, because what we measure may or may not be the essential elements of what happens. We have to look at the components, and most research to date, it's beginning to change, is looking at overall outcome. Alan mentioned some looking at modifiers. We're beginning to look at some of that too with Peter Fonagy. I mentioned a dismantling study, but I think it's very unlikely, to get back to something Alan said, we don't know the truth. We can take ourselves as far as our instruments will allow us to go, but I think psychotherapy is much more complex than what we've been able to measure so far.
Can I just make a short comment? I just want to make a distinction between research on outcomes as opposed to research on process. I don't think for patients like this that the outcomes are really that hard to measure. I think her not self-harming, her staying alive, her improving her relationships, her being able to work, her not giving her husband laxative cookies are easy things to measure. I'm not saying that's the whole story, but for someone with this kind of presentation, that's not a bad start. And I don't think those are hard to measure. I think the processes are hard, and I defer. I think this is where we can come together, because if we could agree on reasonable outcomes, we can establish what treatments have reasonable outcomes, and then it's up to those treatments to figure out how they work, and you can only answer those questions within the model, really, and that's appropriate. I mean, because the concepts are completely different. So but I don't think that part A of that endeavor, it's not. We wouldn't even need to do process research if the treatment we're doing doesn't work. So first we have to know, does it have an outcome that's reasonable, decent outcome? However long you want to say, a year from now, is her life objectively and subjectively better by, reasonable indices? And when we ask these questions, of our patients and their partners or their parents, they have no trouble telling us what those things are, and they agree on what those things are. So I don't think the outcomes are hard to measure. The processes I think, can be very hard to measure. But that's, that keeps us employed.
I would like to thank again both Asti, not both, Asti. Yeah, both Asti and Ruth. Frank and Ellen and Peter that is no longer here. And we open, if you can have, please light on the hall. If people would like to ask a question. אפשר בבקשה להדליק את האור באולם? Does anyone have any question? No, I'm close.
You want a mic?
This frame of working in psychotherapy is sort of new to me, although I recognized the many, many building blocks, and the most important impression was how you put things together and make a breakthrough for people who suffer. What I would like to ask is, what is your way of thinking about breaking the frame while sitting with a certain patient who has special needs and using techniques that are out of your organized principles? I'm concerned about it, especially because of states like when you have an impasse in therapy. Can you, because I believe that psychotherapy is not only science, maybe even more sort of art of using your feelings, instincts, etc. And I want to say that I had I took the courage to do it through the years, and I had some good outcomes in states of impasse. You have to go out of the box and find something else.
Did you understand the question? Yeah? Frank?
I guess I would say with DBT that DBT is very little defined by its techniques and almost entirely defined by its principles and strategies, but not by its techniques. So, so hold on, that's one piece. The second piece is that what you could call instincts, we would call overlearned. You know, so if you've been practicing something a lot, you say you go by, you know, if you're a good chef or a good, you know, soccer player, you say, I went with my instincts, but that's because you've practiced tens of thousands of hours and you have a repertoire within the box, so you're using your instincts within the box. So yes, it's instinctual, but it's not really. It's very overlearned because you've been practicing in a particular way a lot. And so having said that, you know, if somebody suggested using a technique that I've never heard of and it made sense according to a principle, in DBT we'd try it. Why not? I mean, because it's not about the technique. It's about, is it a new and interesting, possibly useful way to achieve something that we're stuck with. With everything I've tried hasn't worked. I would be very happy to try a new technique as long as I have an understanding of the principle that I'm employing with the use of that technique. So it's a very big box, and you can change the size of the box. Yeah, it's totally about principles. I mean, at every moment in DBT, we don't know whether we're going to work on acceptance or change. And as long as we're doing one of those, we're doing DBT. So at any given moment, there's nothing that says we have to do one thing or another out of whole sets of things, as long as we're doing something. And we have to keep them balanced, but balance could be 10 of one and 1 of the other, or 1 of one and 10 of the other. I mean, who knows, you know. Yeah.
Another question?
Oh, sorry. Oh, well, no, if you want to go, I mean, I could just give a short answer because it's a difficult question to answer when you say, do we go out of the frame? Because, or to me, it sounds more like a question about what does one do when one encounters a therapeutic impasse, which certainly everyone encounters once in a while. And let me put it this way. We certainly do sometimes deviate from the neutrality that we generally maintain. And by deviate from neutrality, I mean where we would take an active position about something. But if we found ourselves doing that routinely, then we would think we're doing another therapy, which might be fine. It might be that another therapy is indicated. But if we're going to do what we're calling transference-focused therapy, we do have to focus on the therapist being in the position to analyze the patient's internal world as it's experienced with him or her. And if we became a more active participant in the patient's life on a regular basis, we would think that was shifting to a different form of therapy, which either could be an acting out on our part or could be the right thing to do.
"30 seconds. Thank you very much for the McGee Institute for an amazing Congress, Katniss, how do you say? Beautiful. We're very, very privileged to have experts as yourself come over to this side, you know, of the ocean and be with us. Really, really happy to have you. We were just wondering, though, since hundreds of us in Israel do work with borderline through chemotherapy, why it was missing from this Congress. And perhaps next time we can include that way of treatment, because many of us do work with that. So thank you very much again. 30 seconds.
As we said, this is the first annual, and hopefully we'll have other approaches in the next conference. We're planning another conference on February 2015 2015. So next year we'll try to think of more approaches and deepen the understanding in this one. Yeah, I would like to add another thank you for all the participants in this conference. It was really a mutual work of a group of excellent people who all came and thought and put themselves into real dialogue. And this is what we're trying to promote, and I'm happy, and we're happy to think of more approaches. So if people would like to contact us by mail for the next conference, we're happy to hear about that as well. I would say that we will send you an electronic request for feedback. So please feel invited to add comments, to say what you wanted, what you want more, what was missing, because we would like the next conference to suit the psychotherapist here. So we are the audience, and it should fit us. So I hope that answers the question.
There's a question back there.
Yeah?
Oh, I think the question was about risk assessment. Another part of therapy we didn't have time to go, or I didn't have time to go into, but when we set up the treatment, we deal with parameters or an understanding about how self-destructive or behaviors that are destructive to others will be dealt with. And we make it clear that we're part of a larger mental health care system and that we can't be a crisis manager and a therapist at the same time. This is a principle I think we discussed on Friday. So if Ruth's cutting was not getting better, we would question if there was something in our arrangement that needed to be reviewed, because in our experience, when we set up these understandings and make it clear that emergencies are to be dealt with by the crisis team or the emergency room, we usually see a sharp decrease in acting out, because often that's a form of communication between the patient and the therapist, which we make clear is not going to be a way we want to have the patient communicating with us. We have also found that often we do a disservice to patients to assume that they can't find any element of control even when they're emotionally dysregulated, if you will, because we have found that patients have a combination of dysregulation but some element of ego function that we try to appeal to. So to answer your question briefly, if the risk is too great, which rarely it gets to that in the course of treatment, we'd say hospitalization was indicated. If there was no improvement, we would wonder what was going on, or what was not happening in the treatment, and see if it was the right treatment, needed to be revised, or if there should be referral to another treatment. But in Ruth's case, well, we didn't get into that, but we would have explored a little bit more her recent cutting. The story with the poison cookies was a long time ago, but we certainly are not going to continue an exploratory therapy if the patient is endangering her well-being or somebody else's simultaneously.
And of course, DBT is 180 degrees different from that. We see her crisis behavior as the most extreme example of her dysregulation, and we would help her manage. I don't know if you could tell from the session, but I was doing risk assessment in the session quite a bit I assessed her risk when she came in. I assessed her risk before she left. That's part of the reason I set up a phone call for the next day. The previous time when I had learned about in a previous session, had I learned about laxative cookies, we would have worked on that. That would be on her diary card, or urges to harm her partner would be on the diary card. She'd be actually noticing that every day and reporting it. So it's an integrated part of the treatment and part of the treatment target hierarchy. There are moments when, patients have so many crises that we don't handle all of them, but our goal is we would rather help our patients manage crises in DBT ways, because then there's no split between what they're doing in treatment and what they're doing elsewhere. They're not separate. So, and by the way, the DBT, that it's a very risky piece of working with very suicidal people, and it's also something that DBT is extremely good at. I mean, we're very good at that, and that doesn't occupy the main part of every session, but we're attentive to it in every session, if that makes sense.
As we're after the time we needed to end the conference, I would like to thank my colleague here, and to thank everybody here, and we hope you enjoyed. We enjoyed. And hope to see you next year and in the next conferences we have.